Hey, Dr. C here with you. I want to give you a quick once over about the history of thyroid disease and thyroid treatments. I think it's really helpful to understand why we have the various conundrums that we've got in medicine, the debates that we have, and the conflicts, and also why it seems that people and doctors are at odds. Like the conventional world doesn't seem to really help with symptoms, where that all comes from. It also gives some real context about thyroid medications, why they've fallen into and out of favor, and give you a really good sense about what the future can hold. So I hope you find this interesting. Let me jump in and show you some images. This first one is from an excellent synopsis that was written pretty recently. And this represents something that I've been calling the thyroid renaissance. There's tons of work revisiting all the things known about thyroid disease and rethinking it and trying to see how it can be done better. And that work put together this big overview timeline. So we're seeing starting in the 1880s, 1870s, first identifying some of the conditions, the various types of treatments that were used in these early stages, the different medications that came out, the perspectives, the new technologies, and I'll kind of make sense out of this, but I talk about this in terms of epics, like thyroid epics. So quick overview of what we're talking about. We've got the endocrine system, which is regulated by the brain's organs, the hypothalamus and the pituitary. We've got the thyroid, the parathyroids, pancreas, the adrenals, testes, ovaries. These are all the characters in our play, so to speak, and the thyroid hormones themselves. So the hypothalamus makes thyrotropin releasing hormone to the pituitary, to the anterior front of the pituitary. And that in turn releases thyroid stimulating hormone, and the thyroid releases T3, T4, also releases T2, we now know that, and calcitonin. So those are the main thyroid hormones. And the gland itself is going to sit just below the Adam's apple, a little bit thinner in men and thicker in women, which is why women have a smoother shape to their neck. And then we've got these overt symptoms that come from that. There's those that are thought to be more apparent from too little hormone and those from too much, although these can overlap quite a bit. Okay, so with that preface, and now that you know the players in this, in this play, the characters in this play, here's version 0.0. And this would be from the earliest recorded history to about the 1790s. So back in this point, all that was known was things that were just blatantly obvious to any layperson. So that includes goiter, the swelling of the neck. And this was a problem in many areas. There still are about 4 or 5 countries in the world where this does happen, where there is endemic goiter. That number is down from close to 200 just over a decade ago. So it's really rapidly going away as a global problem, which is awesome. But it's disfiguring, it's painful, and it correlates with many poor thyroid symptoms. Then we have what's called cretinism. And this is where someone is born into a world that's iodine deficient. Now, iodine ultimately comes from the ocean, and there's pockets, there's just small isolated villages that have been high up in mountainous areas, like up in the Alps or the Himalayas. And these areas are so far removed from anything ocean, they can have low iodine in the soil, like really low. And we talk now about how it's cool to have locally sourced food. Well, back then, that's all you had. And if your local source food was iodine depleted, you were iodine depleted because there wasn't really trade or commerce going on. So cretinism, people that had that, they didn't grow up properly. They were smaller and their brains didn't develop very well either. So they were often just marginally functional. And it was observed as recently as the last late part of the 1800s that there were pockets of the world in which cretinism was endemic, in which many were cretinoid in their appearance. And they had major health complications, short lifespans, poor stature, bone issues, and cognitive delays. And once someone hit a certain age, there was no reversing that. The brain has certain windows of opportunity to develop. And when those windows close, they're closed. So this was a tragic condition that has largely been eradicated. We still have areas with endemic goiter, but cretinism itself, thankfully, has been largely erased from the planet. There was briefly time in which an anthropologist thought that what we now know to be Neanderthals were really cretins because they kind of are similar in their brow shape, their skeletal density and their shorter stature, but now we know they are distinct. So during this time frame, here's what went on. The Chinese were aware that seaweed could often help goiter. Goiter was discussed in Ayurvedic medicine. Roman physicians also were aware of goiter, and they used burnt seaweed to treat it. So that was a concept that either was cross-pollinated through trade routes or was discovered independently. Also, in this time frame, Chinese physicians, they used both seafood and animal thyroid gland to treat goiter. So they were giving desiccated thyroid back then. Well, not like desiccated, but just crude animal thyroid. By the 1600s, cretinism was recognized and understood to be related to the rest of this. The term thyroid was coined 1656, and by the end of this window, they first discovered an association between goiter and cretinism. They saw that in areas that had endemic goiter, that there may also be some that had full-on cretinism. They found that these things were related. And there was speculation that it was related to poor water or bad, sick, toxic water of some sorts. And there was partial truth in that there was something lacking, but wasn't solely from the water. Now we've got version 1.0 of the thyroid world. And this kicked off the early 1800s, and a lot happened during this time. So the thought and the focus was, again, on things that were visible, but things that were more so clinically diagnosed. So this is tragic. This is a situation of myxedema coma. And this was recognized and talked about during this 1800 window. This was a case, obviously, from the color photography that was more historically recent. This is from less than a decade ago. And this was a story about a woman who had her thyroid removed, but was not on thyroid replacement therapy. So this is the extreme manifestation of hypothyroidism. And this is the change in a matter of months with thyroid replacement for this woman. So huge, huge shift to health in every way. But this was identified as an additional situation this far back. Now, they also realized that manifestations of overactive thyroid, of Graves' disease with bulging eyes, which can happen, that was also related to thyroid function. And they found that the symptoms, the goiter, the eye bulging, were all related. They discovered iodine in 1811 and realized that it was the thing that could help improve goiter. 1948, von Basedow and Dr. Graves independently defined what we now call Graves' disease. And, in Europe, they call it von Basedow's disease. That is so much nicer. It makes me nuts that we call, that's the worst diagnosis, Graves' disease. It's like a doctor named Payne. I mean, come on, it happens, but if you can choose, why not choose? I wish we could change that. But that came about back when. In the 1860s, French children were given iodine as a prophylaxis and a treatment for goiter, first as prophylaxis, then as treatment. And they saw that it helped many of them. These things are starting to fall into place. 1874, they identified for the first time adult onset hypothyroidism. And they realized it was kind of like a cretinoid state. They called it a cretinoid state supervening in adult life in women. So all these things were coalescing together: goiter, iodine, cretinism, myxedema coma, von Basedow's disease, this adult cretinism. They're all gelling, and there's these glimmers of ideas about them being connected. So 1877, they discovered the parathyroid glands, those little things on the side that control calcium metabolism. They clearly defined myxedema, and a surgeon who had performed many thyroidectomies found that he went back and tracked people down. There was over 200, and he found that most developed this adult cretinism. They realized, wow, when the thyroid is gone, that's another way in which people develop this adult onset cretinism. And they found that thyroid removal could cure some complications from Graves' disease. So myxedema, cretinism, and post-thyroidectomy symptoms were found to have a common cause. They were all related. This was actually one of the first medical photos, which was poor resolution, but this is from 1878, and this was a patient that developed myxedema. So this was the progression of her as that started to show up. So now we got version 2.0, and this goes on from about 1890 to about 1950. So at this point, they're realizing that a deficit of thyroid hormone is the culprit in this adult onset cretinism, incretinism, and ingoiter. So they first started treating that by thyroid feeding. Now, I don't know if you've ever had steak tartare, just, seasoned raw steak. That's pretty much what thyroid feeding was. It was just crude thyroid tissue that you got by the spoonful. And, you know, not the most palatable thing, but shoot, if you think about the complications and avoiding those complications, that'd be worth it. Now, of course, they couldn't dose that in any way that was accurate or consistent or reliable. Oftentimes, too much was given, but it was a step in the right direction. There were improvements. And that's the theme I want you to hold on to, is that each of these steps, we can look back and say, oh, that sounds terrible, right? But it was better than before. And each step was better than before. So we've got further to go yet, but there's many steps that have been taken. By 1891, they really saw the common thread between these hypothyroid states. By 1907, they isolated the first thyroid hormone. And this is kind of funny. This was from a coral, type of coral, and it was actually T2. They found that coral contained T2, and they could extract T2 thyroid hormone from that. By 1916, they started realizing that this state is sometimes obvious, like that poor woman with myxedema coma, but there's probably subtler versions. And how can we diagnose that? And how can we know when someone is getting enough thyroid treatment, when they've had enough thyroid feeding to do better? So they started measuring basal metabolic rate. And they learned that those with thyroid disease had a much lower basal metabolic rate than those who did not. And so some that didn't have the most obvious symptoms, but had an impaired basal metabolic rate, were found when they were at earlier stages of that adult onset cretinism. So that was cool. And they also used that to do thyroid feeding to calibrate it, to get someone closer to the ballpark of an amount that they needed. And then in the 20s, they started using thyroid extracts. So they started purifying the portions of the thyroid they were taking out, not just like steak tartare anymore. And then also they tested thyroid transplant. So they took actual animal thyroid and put that under the skin, usually in someone's butt. And for a while it seemed to work. And they thought and hoped that the animal thyroid tissue set up camp, it had grown blood vessels, and it would keep on going for quite a while. But it turned out it didn't. So it worked because the body's immune system slowly digested that foreign tissue, and in doing so, released thyroid hormone in the bloodstream for a few weeks or months, but then it quit. 1925 through 26, they identified T4 thyroxine and gave that intravenously to treat those who were hypothyroid. By 1950, 1952, they had made commercially manufactured and oral versions of isolated thyroid hormones. Now, during this time, they were already using thyroid extracts, and natural desiccated thyroid had already come about as well. Now we've got the next stage, which is like the 50s to the 70s. So what's going on here is that they've got many thyroid medications. They've made T4, they made T3, they've done some clinical trials, and they've got branded versions of T4 that came out. They're still using basal metabolic rate to see who has thyroid disease and who's getting enough medication. They're also measuring protein-bound iodine. So they're progressing and they're getting better at diagnosing and better at treating. Here's the problem. Here's the big deficit at this stage. Those who were treated had much higher rates of cardiovascular death than people free of thyroid disease did. Now, they were better than those who were not treated. They were much, much more ill in many ways, but they were getting lots of heart attacks, lots of atrial fibrillation, lots of ventricular damage, and overall just poor cardiac outcomes. So that was the big nemesis, was that how do we treat these people and not hurt their hearts while we're doing so? And it seemed almost that it was impossible to separate the two out, that you couldn't give thyroid treatment without causing cardiac damage. And no one knew why it was that people who made their own thyroid hormones, didn't have unusual rates of heart disease, but yet when you gave them thyroid hormones, they did. That was the big conundrum during this window, this what I'm calling this stage 3 of 1950 to 1970. And that conundrum propelled the next stage of research and also the next direction. So now we've got version 4, stage 4.0. This was from 1970 to 1985. And during this stage, some really big things happened. And actually, 1970 to 1973, a ton of stuff happened. So we were, I'm sorry, but I'm a space geek. So this is what was happening in, if this was the Apollo 13, the Eagle, or Apollo 11, Eagle has landed, this would have been July 25th. No, they took off July 25th. This would have been like the end of July in 1969. But anyway, there was big stuff going on during those first years of the 70s. So one of which they learned that T3 is mostly made outside the thyroid. 80% of it is made outside the thyroid after the thyroid has released T4. They also learned about how to measure TSH. They understood what it did and how to measure it for the first time. They realized that when the TSH was too low, that's when people were getting cardiac death. Also in those years, they were able to measure T3 and T4. And the culmination of this was in 1984, when JAMA basically said that natural desiccated thyroid, because it was from animals and because it had T3, they called it obsolete therapy. And back then, many companies were making it, and it was not as consistently standardized. They standardized it based upon iodine content, not on hormone content. Starting in 85, they standardized it based upon hormone content, and things changed. But the thought was, if TSH is too low, that's where heart disease comes from. That was true. And that the body can make all the T3 that it needs without taking T3. Well, that wasn't totally true, we now know. But because there had been so much concern about cardiac death, rightfully so, there was a strong embrace and a strong welcoming of this next level of technology. The thought was, we can use TSH to see who has thyroid disease and who's taking enough thyroid hormone. By doing so, we can safely treat people. And the rates of cardiac death from thyroid treatment plummeted. And there were many people that were successfully treated. They felt better. But there's still more refining yet to go. It wasn't totally done yet. So the next stage started in about the mid 80s. And here's a comparison I'd like to just talk through real quick. So you can see how the green is thought to be optimal, and the red is like, too high. The yellow is like starting to get too low. What this is showing is that the range of cardiovascular risk and TSH levels, when you're only on T4, you can be, your TSH will keep you in a range to where you're safe for your cardiovascular health, but you may well be low on your basal metabolic rate, and you may well be low on your energy. It was hard to line up all those factors. So that was a struggle that was taking place in the mid 80s. Doctors were safely treating people, but many of them were tired and they had a suppression to their metabolism. They were gaining weight or not able to lose weight or still seeing some symptoms. That was the conundrum of the day. And what we've seen since then is that the TSH really is a valid predictor, that when it's too low or too high, there is a higher rate of death. This was a recent study that was done in 2019 that encompassed over 1 million data points total. And the paradox, though, is that the TSH is a stronger predictor of death when it's low, but it's not a strong predictor of death until it's very high. So if someone's TSH is at least not low, they won't get heart disease, but they may not feel well. So TSH is easier to use by itself to prevent death than it is to really dial in overall well-being. And to have people feel well, it takes being more exacting on type of treatment and also secondary factors that affect their symptoms. And that was the pitfall during that window. And because of that, there started emerging some contrarian views. Broda Barnes wrote his first book about the ties between thyroid disease and the heart attack. He argued that both directions could cause it. It wasn't just from taking thyroid hormone, that low thyroid could also cause it. And that has been borne out, however, only at more extreme levels. He opened a foundation. We also saw Dr. Wilson's work emerge during the later part of this window. He followed a lot of Barnes's ideas, but argued that the culprit was not enough T3 and T4 was the problem. T4 and reverse T3 were the problems. Mary Shaman started writing about this. Later on, we had Stop the Thyroid Madness and the Thyroid Symptoms books. So in this time, there was just a palpable sense of patient dissatisfaction showing up because people were treated, they weren't getting heart disease from it, but that was so long ago that it was no longer seen as a recent victory. It wasn't a sense that there was anything to be victorious from because that was distant, but people just knew they were suffering and not feeling well. In the next few years, in 2010, uh, the internet and social media made these concerns much more apparent, and patients got better connected, and they realized that that they were part of an underserved population. In 2018, the American Thyroid Association surveyed their followers on their website and that of their members and asked them, how satisfied are you with your treatment? And it was poor. The results were very poor. This graph shows level of satisfaction from 1 through 10. So if the treatment was perfect, it would have been all here and flatlined elsewhere. But there was many that were completely dissatisfied and few that felt good. But most were in these levels of dissatisfaction. Almost everyone was. However, during this time, those who were on natural thyroid or who had doctors that were prescribing them more carefully, they had higher levels of satisfaction. So the American Thyroid Association was seeing this. So here's a quick synopsis of what was going on. So there's been many versions of natural thyroid. We now use natural desiccated thyroid, but there was also thyroglobulin and thyroid extracts that were in use in parallel for quite some time, as well as T3 by itself. So right now, the main emphasis is using TSH for diagnosis and T4 only for treatment. But that's this stage. So what about the next stage? We've gotten past the idea of being able to diagnose this well, to see it at earlier stages. We're able now to treat in ways that don't cause cardiac damage, although many in the natural space that emerged in the mid-'80s, they do disregard those concerns. They've not seen those issues for some time, so they don't think they're real anymore, but they are. But nonetheless, people are dissatisfied. So the thought is that this next stage is starting here, and it's going to have to include looking at a full spectrum of treatment options for people, looking more narrowly at optimal ranges, not just normal, understanding that there's many conditions that overlap with thyroid disease and properly diagnosing them and treating them, and really realizing the role that iodine plays in suppressing thyroid hormone output. So that's where version 6.0 starts. I'm really excited to roll more of that out with you, but hope that context was useful. Dr. C here with you, and I'll see you real soon. Bye-bye.